Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher. We are at the 142nd episode of the Codecast today, and I'm happy to say we have almost 150,000 listeners, so thank you for your support and your constant positive feedback on the Codecast. Also, I wanted to shout out to Kat and Ruth. Ruth, thank you very much for your always kind words. And we were texting the other day. I love my podcast listeners. And I look forward to each Tuesday to bring you the latest and what's happening on the healthcare platform. Hello to Claire and just everybody who's been liking my Facebook page and all of that. So definitely appreciate all of you. Now, today is kind of interesting because I really try to bring you what's latest on the healthcare platform, but it's tough sometimes because I have things that are planned. But today was actually an unplanned episode. A couple of things that came up that I really thought it was important that you got the information as soon as it was available. So first thing I wanted to put out there, because I know some of you have now started getting on those biweekly calls, office hours calls with CMS, and I just wanted to make sure, in case you haven't, that you heard what they said on their last call. And what they were talking about is the extension of the public health emergency, so the PHE period, which means how long will we continue to have the waiver flexibilities under 1135. And so what they've said is that the plan is to be extended to October 26th, because right now it's supposed to expire as of July 26th. That was the update we got in April. But I'm right now on the phe.gov website, and it has not been put in writing yet. So it was only on the office hours phone call. And so just make sure, again, phe.gov, and right when you pull it up, it'll tell you how long the public health emergency will last, when's the next expiration date, and when the last update was. So always keep that on your browser so that you have it to keep posted. Okay, so especially if I'm not able to give you the information right away. So today I was actually going to speak on medical necessity, but we also have another new policy in place by Medicare, and it was actually effective July 1st, which was just a few days ago, and it could affect many of you listening today, so I wanted to make sure that you had it. And Medicare has adopted a new, what they call prior authorization program. It's almost like what you have to do to pre-cert certain surgeries. And as of June 17th, the Medicare Administrative Contractors, so the MAC carriers, which is at the local level, were required to start accepting requests from hospitals. Now, this is a Part A program, but it does affect Part B dollars. And I know many of you are physician coders, so that's why I wanted to make sure you had the update. Financially, CMS has said that it will cost them about $7.4 million to administer the program, to review about 120,000 procedures that are performed each year, with payments of about $115 million. What that means that at least 6.5% of all requests must be denied for Medicare to save that money. And that's a pretty high hurdle if the goal is to protect the Medicare trust fund. I think some people forget this is a trust fund. But ensuring that the trust fund money is spent properly, it's also a goal worthy of pursuing. It's also important to note that this is a nationwide program, but it relies on the local decisions of, again, the MAC carriers. So if you put their medical necessity standards next to each other, there are certain differences. For example, a paniculectomy. Sometimes it's hard to say that word, but what that is a procedure that is a surgery, and basically it's to obviate extra and excessive amount of tummy and abdominal fat from the lower abdominal portion of the body. It's typically for patients that have had weight loss surgery, a weight loss surgical procedure, and it's solely performed just to get rid of extra fat and skin in the abdominal and stomach and abdominal areas. And it's different than some of the other services because it's really just focused on the abdominal area there. But for example, the abdominoplasty would be abdominal and stomach muscles instead of just getting rid of the excess fat there. So that's one of the areas. But the reason I bring that up as an example is that this is actually commonly performed after bariatric surgery, again, when patients lose a significant amount of weight. But Palmetto Medicare will not approve a pannulectomy unless it has 18 months passed since the bariatric surgery. Novitas, on the other hand, won't approve it for 24 months, and they also require the BMI to be less than 35. Then you've got Noridian, which is in my state in California, and they won't approve it for 24 months. BMI has to be less than 35, and you have to have a second opinion that it's medically necessary. So the health system covers multiple MAC jurisdictions. You better make sure you know what your state requirement is. So it's going to be very interesting once the program gets rolling. And since it's Wednesday, July 1st was the first day that the prior authorization was required, Medicare beneficiaries are going to have to be careful, and so will you as far as getting this authorization. So let's take a look. So there's certain things you need to know about the program, and I like making lists. So here's the top 10 things I found from that. And again, sometimes I do these on my top 10 Tuesday at the end of the month, but when this first came out, and since it's only a couple days new, I just definitely wanted you to have it. So 5 types of surgery fall under this. Blepharoplasty, botulinum toxin injections into the face, pannulectomy, like I mentioned, rhinoplasty, and then vein ablation. So my cardiovascular physicians out there as well. And when these are performed in traditional Medicare beneficiaries at hospital outpatient departments, they will require authorization as of July 1st, 2020. So now it is the duty of the hospital, and that's number 2, to obtain prior authorization, even though the physician determines medical necessity and schedules and performs the procedures. So as physicians, you can assist in the process or perform the entire process if you want to, but the onus is really on the hospital to ensure it's properly completed prior to the performance of the procedure. So number 3 is each MAC carrier will publish its own medical necessity requirements. Make sure you're checking their website, and we call those LCDs for each procedure, either through their local coverage determination or guidance and guidelines published on their website. Or they may use a specialty guidelines and established standard of care guideline and just use the national decision. So it just depends on what that is, because right now there's no national coverage determination. There's only narrative for any of these procedures. So they're really looking to the MAC regional carriers to understand what will be paid and what won't. And some of those regional differences could be significant. If the MAC determines that medical necessity is met, it will issue what they call an affirming decision and provide a unique tracking number. It's called a UTN that must be placed on the hospital claim. Okay, but this is not to be placed on the physician claim, but it's nice that if you have it. So I would ask the hospitals, when you have these certain procedural codes that are going to fall under this, that you at least have it if you need to appeal. Prior authorization, this is a condition under the payment policy, and I want you to write this down or remember this, 42 CFR 419.80B as in boy. So if an affirming decision is not obtained or procedure is performed without this affirming decision, your claim will be denied. And I usually like to use the word may be denied. It will be denied. Hospitals can appeal the denial, and if medical necessity is established, then you may get paid after the fact. But this is a pre-authorization program, so you have to understand the program. Now, a denial of the hospital claim, and this is where you come in as a physician practice, will also result in all associated claims being denied. So that means the surgeon or physician, the anesthesiologist claim, the radiologist claim, the pathologist claim, and anyone else who submits a claim under the hospital procedure. So meaning that, anyone that's tied to it. These claims will be denied either pre or post payment, depending on your MAC's processes. So each provider also has to, if you have to appeal, you'll be required to appeal the denial separately. So a successful appeal by the hospital or surgeon doesn't result in an overturn of a denial for other providers. So you'll be responsible for your own medical necessity and getting medical records and submitting them with your appeal. That's why it's important to make sure you have that authorization number for the hospital. Not that you should put it on your claim, because it'll just mess things up. So again, that UTN or unique tracking number, have it in your back pocket for an appeal. Because if you, for example, if you're a Coding Corner client, I'd ask you for that so I can assist you in your appeal if this ever comes up. then the MACs will have 10 business days. So they have a 10-day window to complete their review and issue an affirming or non-affirming decision. So you notice how they don't call it a pre-authorization, affirming or non-affirming. It's almost like a thumbs up or thumbs down. And providers may request an expedited 2-day review if the delay would endanger the health or life of the beneficiary or his or her ability to regain maximum function. So the MACs are not obligated to perform an expedited review if they feel that the request is unreasonable. And you go back and you look at what the surgeries are. I think it would be tough for the pannulectomy unless the extra fat from that surgery, from the bariatric surgery on that patient, was causing an obstruction. A rhinoplasty, you could probably have a good argument because it affects the breathing of a patient. Vein ablations, those are pretty elective, so I'm not sure. Definitely not botulism and toxin injections to the face. Blepharoplasty, you definitely would have an argument. So just know the difference in some of your services. Number 9 is if the MAC issues a non-affirming decision. So the provider may resubmit information as many times necessary to meet the medical necessity requirements. But remember, every time you submit something, it has to be different. It can't be the same information. So hopefully you have enough information and you were able to get an affirmative decision before you have to appeal it for a non-affirming decision. And it says a provider at any point may accept the non-affirming decision and has the option to issue an ABN to the patient. That means you would have to have a GA modifier on the claim or perform the procedure without the affirming decision or ABN, knowing that it will automatically deny and you may have to appeal. So it's not saying that it's not covered. It's saying that they may not approve it based on their policies for medical decision making, and the patient may have to pay. So the MACs are permitted to develop cover sheets or checklists for providers to aid in the submission of these requests, but their use is not mandatory. So you can develop your own processes for collecting and submitting the required documentation. Some of these procedures I've also noticed from one MAC carrier, Novitas, they want pictures, so photographs may be required and so make sure you have a way to transmit them with adequate resolution is going to be important as well, either through a portal or through, especially if you're doing any kind of rhinoplasty or blepharoplasty, they're going to want to see, even maybe possibly a vein ablation, they're going to want to see the severity of that, and that may help you with the authorization. But the hospital is the one that actually has to make sure that they get the authorization for the facility, and then but the physician could be basically, I hate to use it as guilt by association, but could be affected because of a denial that the hospital may get, or they may not get the information correct to be able to get their authorization. So just keep on top of that. Make sure you're looking at this from a Medicare perspective because it just became effective. So, search it out and make sure you look that up as far as their prior authorization program. Okay, so today's topic was brought to you by FormStack, a secure workplace productivity platform built to produce solutions to the everyday work that slows organizations down. FormStack is a data collection and management tool that allows you to build forms and surveys in minutes and store your submissions in an encrypted database. FormStack maintains HIPAA, GDPR, PCI, and WCAG compliance. If you're looking for a hassle-free way to revamp your data collection process, look no further than to FormStack. Visit formstack.com/codecast to learn more and sign up for a 14-day free trial of their solution. formstack.com/codecast. Okay, so let's look at our coding question today. I like this question. This one's actually kind of interesting. This one comes about no-shows. And when I've been hearing some of the, catch up from telehealth and how people aren't there when they try to call them for their appointment. Now, I've heard the other side of it as well, where some patients have been on hold for an hour, basically a virtual waiting room trying to get in. So try not to do that to your patients. Their time is valuable too. And I know that it's one thing to have them wait in the waiting room, but on a virtual waiting room on the phone, what they're going to do is they're going to put you basically on speaker, which then becomes absolutely non-HIPAA compliant, and start to go cook in the kitchen or bake cookies or let their grandkids in or whatever. And then they forget that somebody's on the phone. But anyway, our coding question says, so this is one of my Washington, D.C. subscribers. It says, Terry, our office has taken a financial hit since we've been drastically reduced in our hours due to the coronavirus pandemic. Okay, like everybody. While reviewing ways to bring in more money, we decided to consider charging insurers for no-show visits. How do we do this? Okay. So you can institute a no-show fee to offset some losses you've incurred recently, but you should never bill these no-show charges to payers unless you have a specific contract so they're going to pay them, and I guarantee you don't. These are billed to patients for missed visits. So first thing is, and I'm sure you've heard of surprise billing that's prohibited, you first must make sure that your patients are aware of a policy that you have. So this typically happens when the patients first join your practice. They sign a financial contract with your office. But if you didn't have a no-show policy to start, then tell patients about it before you institute any charges, and make sure that you've sent something out since you're not seeing a lot of patients in the office yet. But you have to have a policy written in place in your compliance and your operations manual that your patients have seen, and it's helpful if they've signed it on their intake information. But if they haven't, you have to show proof that you've informed. Payers may only be charged for rendered services of medical services and or supplies utilized on the patient. So no-show appointments means that no patient showed and they didn't show up, and so no medical services are performed. So billing the payer may not be appropriate. Now, if the patient says, oh, my payer pays for it, then just make sure under your contract. Now, some coders I've noticed are using the 99199 code. That is an unlisted special services or procedure report in the E&M section. I wouldn't use that. I would use an internal code because the code descriptor is very vague, and sometimes offices have used that to set up an internal charge code, but it generates a patient bill. Now, you need to have something internally, but something you can track. And what if you had to use that again for something that you actually could bill for? So remember, when you use an unlisted code, it means it's something you can bill for. Since you can't bill for it, you're just trying to generate a patient bill, then I would use an internal code that you've made up. Now, no one likes to lose patients, and patients who consistently miss appointments definitely can result in practice financial liabilities. If the problem reaches a significant percentage of your patient base, it may be in the practice's best interest to possibly terminate the patient relationship with that particular patient. If the etiquette is clearly outlined in your practice policy, an office can decide to refuse a patient after a certain number of no-shows. So some practices will send letters to the patient after, say, 3 no-shows before dismissing them altogether from the practice. But if the patient was never seen from the practice, don't make any more appointments, and notify the referring provider as well if there is one, just to make sure they understand it. But I would strongly also advise you to get legal jargon and understanding about patients that are existing, that you're following their care. You don't want to have any kind of legal situation for abandoning a patient, because typically when you discharge a patient, you have to give them an option of where to go. And then also make sure that you are in agreement as a group from a compliance standpoint, and you have it written up everywhere on how you handle no-shows. But I know this is becoming even more of a problem now that we're dealing with telehealth, and you have to be able to protect your practice. Our coding question was brought to you today by Modern Healthcare. Modern Healthcare Magazine, award-winning healthcare business news, research, and opinion, modernhealthcare.com/subscribe. So I'm going to end this week. I know I had kind of a short program this week, but my personal tidbit is actually a recipe. So I know we just came off the 4th of July, but I'm kind of obsessed with this salad. And if you follow me on Instagram, you get to see all fun stuff. I'm in Terry, it's at Terry and CA, and I actually had my hair done this last week, so I was really excited to get some of the gray out, and I put my photo having that done, and I got a lot of funny comments. Everybody's like, oh my gosh, that is hilarious. But I make this salad, and I make it all the time, and I'm kind of obsessed with it right now. And it's just a nice summer salad, goes with everything, very inexpensive to make, and easy. It's basically 1 cucumber peeled and seeded and chopped into bite-sized pieces, a half a shallot, which a shallot is between a white onion and a purple onion. They're smaller, but it's not as strong as a purple red onion can be. And then, so you use about half of that, a firm Roma tomato. I don't like like squishy tomatoes, and slice it up into bite-sized pieces, and about 1 tablespoon of feta cheese, and fork it even more to crumble it more. It should be really crumbly. And then about 1/8 of a cup, which is about 2 to 3 tablespoons of Italian dressing. I just use the cheap one, the Kraft Zesty Italian, 99 cents a bottle. It's great. And put the lid on your Tupperware and shake it, and it's ready to eat in 10 minutes or longer. And it marinates. The longer it marinates, it's better, but it is awesome. Lasts for 3 days. It's still crunchy. It's awesome with steak or anything you want to eat it with. Glass of red wine. But let me know if you made it and tell me what you think about it. Now that we've had a couple of restaurants starting to close again because they don't have outdoor seating due to the spike in some corona cases we've had over the last 10 days, you may need some new recipes to try. So I'm going to add some on my personal tidbits in the next couple of weeks, and they are going to be crowd pleasers, very economical, and things you can just either throw into the crock pot or make in like 5 to 10 minutes. And I'll also put photos on my Instagram account so you can see what they look like. But again, it's, you know what, we have to figure out new things to make at home, and hopefully I'll help you out with that. And some things that are good and things that we can save money, and you can see, if you like them or not. So I really appreciate everyone. Hopefully you got some good information from today, and that you're staying safe. As far as the wearing a mask and social distancing and all of that, a couple of things have come out this week, and actually today from the Surgeon General about wearing a mask. And what he said was basically, if you can't social distance, which is that 6 feet, then if it's not family members, and if you need to wear a mask in areas where there's other people, then it's helpful if you can put one on. So if you go, from and to the grocery store, if you're walking into a place that you need to buy something and there's other people in there, just put it on quick, and then you can go back to your car. I'm not wearing one in my car by myself. I think that is just silly. Now, if you feel comfortable doing that, then feel free. Absolutely. I would never shame anybody into, wearing a mask when you feel comfortable. But I always want to say Attorney General, what the Surgeon General said was that only if you can't social distance. And if you're outside, it's really just up to you, again, what you feel comfortable with. Now, being around people, that's where the issue is. So make sure that you look at the Surgeon General's platform. I try to look there instead of just CDC, because sometimes you get misleading information on a lot of this and on a lot of this stuff when it comes to corona. So do your own due diligence, do what you're comfortable with, and let's hope that at some point we can get out of what we're dealing with right now. So make it a great day and a great week, and thank you for listening to the Codecast podcast. Stay safe, everybody.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.